Let's talk about FOLFIRINOX. It's a triplet chemotherapy regimen, very effective and often first line for many gastrointestinal cancers such as pancreatic and colorectal cancers. FOLFIRINOX regimen includes three chemotherapeutic agents with a one anti-tumor effect enhancer. That means one drug in this combination is not a true chemotherapeutic agent, that is the folinic acid. It cannot kill cancer cells its own. Folinic acid is given to the patients in the form of leucovorin. Let's break it down. FOLFIRINOX. Like I said, folinic acid given in the form of leucovorin is an effect enhancer for the primary drug in the combination called 5-fluorouracil. This drug is the backbone of this regimen. The other two drugs are Irinotecan and Oxaliplatin. Both are synergistic with 5-fluorouracil. Another version of this regimen is FOLFOXIRI. This has a modified schedule with a low dose of irinotecan. Like typical combination therapy, these drugs also have different mechanism of actions and adverse effects. Let's talk about how these drugs work. Mechanism of action. All these three drugs target the DNA of the cancer cells but with entirely different mechanisms. First of all, the 5-fluorouracil or 5-FU. It is a thymidylate synthase inhibitor. This is the sole enzyme responsible for de novo thymine synthesis. That means the only way to synthesize thymine in cell is through the enzyme thymidylate synthase. If you block this enzyme, there will not be any thymine production in the cell. So 5-FU is a synthetic fluorinated uracil. 5-FU metabolite covalently binds and blocks thymidylate synthase enzyme. But this binding can be detached very rapidly. Therefore, we add leucovorin. Metabolite of leucovorin acts as a molecular cap, thus strengthens the binding of 5-FU to thymidylate synthase. As a result, rapidly dividing cells undergo thymineless death. The next drug is irinotecan. That is a prodrug. Its active metabolite is called SN38. Both bind and block topoisomerase I enzyme, thus prevent DNA religation. Cells undergo replication arrest and then apoptosis. How is that possible? Inhibition of topoisomerase I accumulates reversible single-strand cuts, but later leads to irreversible lethal double-stranded breaks. That's how this happens, and by topoisomerase I inhibition. The next drug is oxaliplatin. That is an alkylating agent. Unlike nitrogen mustards, this is a platinum analog. It is an atypical alkylating agent resulting intrastrand cross-linking. All three mechanisms completely blocks the DNA of cancer cells. That's why this regimen FOLFIRINOX is very effective. Let's look at the adverse effects. First of all, the 5-fluorouracil or 5-FU. Continuous infusion is preferred over bolus to avoid myelosuppression or bone marrow toxicity when you use 5-FU. But mucositis is also common for this drug. When you do continuous infusion, increased dermal toxicity is common. It is by the accumulation of 5-FU and its metabolites in keratinocytes that can result hand and foot syndrome with a dry, rough, flaky skin, it starts with a painful redness, but later turns into blisters in the palms of hands and soles of the feet. 5FU deactivation and elimination is by the enzyme DPD, dihydropyrimidine dehydrogenase. Toxicity increase in patients with a less DPD enzyme expression. Toxicity also increase in female gender and in patients above 70 years of age. Keep in mind, DPD enzyme assay is available to test the patients before giving this drug. Since leucovorin is increase the efficacy of 5FU, toxicity can be higher with leucovorin. But the next drug is irinotecan. Irinotecan's classic adverse effect is diarrhea caused by the active metabolite called SN38. About 80 to 87, 90% patients develop diarrhea. Acute diarrhea during drug infusion or within 24 hours of infusion shows cholinergic symptoms, but delayed diarrhea after 24 hours of infusion causes severe dehydration and electrolyte imbalance. It can be life-threatening often. SN38 induced intestinal mucosal damage is the cause of irinotecan induced diarrhea. Elderly patients 65 and above are in higher risk. UGT1A1 enzyme deactivates SN38. Therefore, low UGT enzyme increases the risk of diarrhea in patients. Keep in mind, UGT enzyme assay is available to test the patients before treating with irinotecan. The next drug is Oxaliplatin. It has the most severe adverse effect in all the drugs in the FOLFIRINOX regimen. Peripheral neuropathy is the major symptom or adverse effect. Irreversible sensory nerve damage can disable the patient often. About 90% patients get neurotoxicity in different forms. Oxaliplatin binds and damages mitochondrial DNA of sensory neurons, which can later kills the nerve ending in some peripheral parts of the body. Cold sensitivity is also another notable adverse effect in patients taking oxaliplatin. It is a reversible peripheral sensory neuropathy triggered by cold temperature. Oxaliplatin-induced peripheral neuropathy is unpredictable. Unlike other two drugs, there is no enzyme assay available to predict this drug's risk. Okay, and next is mnemonics. How I remember about 5-fluorouracil's hand and foot syndrome is 5 fingers in hand. That's how I remember. Then irinotecan caused diarrhea. That is, I ran to the can. Irinotecan, I ran to the can. So diarrhea somehow. And oxaliplatin, I have no idea how you are going to remember, but I want you to remember two adverse effects, very important. Peripheral neuropathy and cold sensitivity with the oxaliplatin. Out of all these three drugs adverse effects, peripheral neuropathy or neurotoxicity is severe in oxaliplatin compared to all the other drugs adverse effects. And this is also important for your board exam, so keep in mind. Then FOLFIRINOX, it is a triplet chemotherapy with 3 chemotherapeutic agents and one drug function enhancer. But in doublet therapy, we can use 2 drugs. For example, 5FU added with the irinotecan is FOLFIRI regimen, and FOLFOX regimen we replace irinotecan with the oxaliplatin. This is based on the adverse effects of patients, so we can pick based on their enzyme test. Then Capox is another form of FOLFOX. So here we replace 5-fluorouracil with its prodrug called capecitabine. That is actually an oral drug. So capecitabine combined with oxaliplatin is actually another doublet chemotherapy. In patients with a metastasized cancer, we can use these regimen with a specific target therapy. For example, if a patient has a HER2 positive cancer, use one of this regimen and add trastuzumab. Similarly, we can pick the drug. And anyways, summary, FOLFIRINOX, in this 5-fluorouracil remains the backbone of this chemotherapy regimen. Leucovorin, that is folinic acid in the form of leucovorin, that increases 5-fluorouracil's activity. And the next two drugs, Irinotecan and Oxaliplatin, have synergistic effect with the 5-fluorouracil. Let's look at a case, a 66-year-old male being treated with a FOLFIRINOX for pancreatic cancer presented with a severe diarrhea and dehydration. Which of the drug in this regimen is the causative agent? So you have the list of drugs in this regimen. So as you know, leucovorin along with a 5-fluorouracil will not increase the risk of diarrhea, but mainly that is inducing the hand and foot syndrome. But it can also cause mucositis, like I said, and bolus regimen can cause bone marrow toxicity. But oxaliplatin can cause only the cold sensitivity and peripheral neuropathy. But irinotecan is the major causative agent for diarrhea in this FOLFIRINOX regimen. So the answer is irinotecan, but keep in mind, if it is an early or acute stage, acute diarrhea, we can use atropine because it shows cholinergic symptoms. But if it is a delayed diarrhea, we can use loperamide. And the last thing, one more point to remember, this is called CID, chemotherapy induced diarrhea due to irinotecan. I want you to distinguish that with a C. diff diarrhea, C. diff induced diarrhea, that is actually an antibiotic associated diarrhea. Example, clindamycin. I will make other videos to explain all these drugs and adverse effects. So hope this helps. Study well and all the best.